Hello, and welcome to our online training on engaging boards in patient-centered health home transformation. My name is Wendy Nakatsukasa Ono, and I'm Program Director for CARDIA. On behalf of the California Primary Care Association and CARDIA, my colleague John Perkins and I are pleased that you've selected this module to support your professional development. CARDIA is a nonprofit, mission-driven organization with a principal team of committed and passionate staff. We've dedicated our careers to helping health and human service providers offer their best to the patients they serve. You may be aware that CPCA is offering this training as part of its Patient-Centered Health Home Recognition Program. This initiative is designed to support member clinics' efforts to move toward and achieve National Committee for Quality Assurance, or Ncqa, recognition. In this session, we're going to describe the duties of a governing board, both general duties and those specific to governance requirements of the Health Center program, and outline strategies for engaging boards in patient-centered health home, or PCHH, transformation.
Let's start by talking about the general duties of a governing board. A governing board has fiduciary responsibility for the organization's well-being. In other words, the board is the steward of the organization's financial and legal affairs. In addition to the board's responsibilities as a governing body, individual board members are bound by three legal obligations: duty of care, duty of loyalty, and duty of obedience. The duty of care describes the level of competence that is expected of a board member and is commonly expressed as the duty to use reasonable care when making decisions as a member of the governing body of the community clinic or health center. To exercise duty of care, board members must actively participate in board meetings and related activities, review committee activities, support board actions, and have knowledge of the records of the organization and ensure accurate record keeping. Contribute to instituting proper internal controls, contribute to obtaining resources, and investigate warnings and reports of mismanagement by other board members and employees. The duty of loyalty is a standard of faithfulness and is commonly expressed as the duty to act in the best interest of the community clinic or health center. To exercise duty of loyalty, board members must put the best interests of the organization first and avoid engaging in transactions that would result in gain for them or a member of their family. Board members are not necessarily prevented from engaging in transactions in which they have financial or other interests. However, they must fully disclose any conflicts of interest in writing, and the transactions must be approved by other board members in good faith. The duty of obedience requires board members to be faithful to the organization's mission and act in ways that are consistent with the central goals of the organization. To exercise the duty of obedience, board members should be familiar with applicable federal and state statutes, filing requirements and governing documents, and obtain opinions of legal counsel or accountants when appropriate. The National Association of Community Health Centers, NACs, governance requirements of the Health Center program flow from these three duties and include specific requirements to assess and monitor the needs of the target population, including overseeing the organization's progress in meeting its mission and goals, and reviewing an updated written needs assessment document before engaging in strategic planning. Approve the Health Center program grant application, including reviewing the proposed activities against the budget requested. Adopt a sliding fee discount program within the broader context of adopting policy for financial management practices. Approve and monitor the annual budget as part of a realistic plan for achieving the organization's annual program and financial goals. Review the independent financial audit, including selecting the auditor and ensuring that management resolves audit findings. Monitor financial performance using financial statement data. Establish a quality assurance or quality improvement program, including improving the annual QA and QI plan and making sure the plan is being implemented effectively. Select services to be provided and hours of operation, as well as determining whether or not services are provided by staff or through referrals, and engage in long-term strategic planning. At this time, I'd like to share a 5-minute video from NAC entitled, "What's Different About a Community Health Center?" In this vignette, the CEO of a health center talks with a prospective board member about why her perspective as a long-term patient is critical to the health center's capacity to support and encourage a patient-centered approach and ultimately be a health home for its patients.
Community health centers strive to be patient-centered. So if the patient really does come first, how does that impact your role as a board member?
Come in. Hello, Ms. Johnson. Welcome to the Billing Community Health Center. Take a seat. Would you like some coffee or tea?
Oh, no, thank you, Mr. Smith.
Please, call me Bill. We'll be working together. Besides, that seems too formal. Can I call you Connie?
Yes, of course.
I take it you wanted a little more information about your board membership duties before your first meeting?
Well, actually, I had something else on my mind. I think that I'm way out of my element here.
Why do you think that?
Well, as you know, I've served on community groups in Belford for many years, but it was never a formal position. We had more volunteers than we had paid employees. You know, here at the Community Health Center, you're a professional organization, not a volunteer group. And I get my health care here, too. I'm a longtime patient. I want to be very cautious about offering any criticism.
Wait a minute. Why do you think we asked you to join the board?
Well, I think it's because there's a requirement that you have to have a certain number of patients on the board. Is that correct?
That's true from a compliance viewpoint, but it's not why we want you on our board, Connie.
It's not?
Connie, what do you see as the difference between the way we operate here and how other medical offices and hospitals operate?
Well, there's a big difference. It's better coming to the health center. People are friendly. They seem to care about me. They don't just rush me out the door and give me a prescription.
You got it. That's the difference. We're patient-centered, and that's how we want to be perceived at all times.
Given that you're federally funded, though, I mean, isn't that all spelled out in the rules that you have to follow to run a community health center?
That's correct, but we go way beyond that. We want to be a home for people in need. Actually, we want to be more than a medical home. We want to be a health home. We want people, regardless of their ability to pay, to feel that this is their home for better health. We want them to feel comfortable and respected. That's what we mean by patient-centered.
That's great, but could you give me some examples of what you mean by a medical home? I mean, that's a very unique term.
Sure. When you enter our community health center, we take notice. If you have to wait, we'll keep you informed about our current wait times. And you won't see any frowning faces rushing around here. You'll see people who want to work together in a way to help and support each other.
That's wonderful. Well, so what's my role as a board member?
The reason we want to have patients on our board is very clear. We want you to make sure that we live up to the idea of being patient-centered. In that sense, your experience here makes you well-equipped to give us valuable feedback about the quality and care that we provide to our patients. And because you live right here in the community, that makes you ideally suited to let us know if there's something we should be doing differently, and to make sure we're connecting with the people who need health care.
Let's think about the idea of providing health services in a way that is patient-centered. This will help Mrs. Johnson and maybe yourself continue to promote this concept. Here are a couple of questions to help guide your conversation. As a board member, what would you look to see inside a community health center to know that it is patient-centered? What is the board's role in supporting and encouraging a patient-centered approach to care?
I hope you enjoyed the video. Ncqa has a variety of other resources on its website, including other videos and discussion and resource guides. A link to NAC's Board Education video series is provided on this page.
Let's talk about engaging boards in PCHH transformation within the context of these general duties of a governing board and the governance requirements of the Health Center program. Becoming a PCHH is about transformation at many levels. Transforming the way in which we think about patients and their families' roles in healthcare, transforming the redesign of primary care, transforming payment systems to reward improvements in health outcomes, and transforming our healthcare system to put primary care at the center in promoting health and wellness. With that in mind, let's start at a high level by talking briefly about a framework for driving and sustaining transformation. Depending on your board's familiarity with the Institute for Healthcare Improvement, IHI, and its model for improvement, you may want to use the next few slides as part of your work to engage the board in PCHH transformation. If your board is not familiar with the IHI model for improvement, IHI has a number of resources on its How to Improve page. A link to the How to Improve page is on this slide. IHI's resources include the on-demand course, An Introduction to the Model of Improvement. A link to the course is provided on this slide. Now, let's turn to the framework for driving and sustaining transformation. In 2008, IHI published a second edition of its white paper, 7 Leverage Points for Organization-Level Improvement in Healthcare. As indicated in the white paper, these leverage points are specific activities for leaders and specific changes in leadership systems in which a small change might bring about large, positive, system-level results. A link to the white paper is provided on this slide. These 7 leverage points are, first, establish and oversee specific system-level aims for improvement at the highest governance level. And second, develop an executable strategy to achieve the system-level aims and oversee their execution, again at the highest governance level. Because these 2 leverage points refer to the highest governance level, these are the 2 places for boards to focus. We'll return to these points in a moment, but let's finish reviewing the remaining 5 leverage points. Third, channel leadership attention to system-level improvement. Fourth, put patients and families on the improvement team. Fifth, make the Chief Financial Officer a quality champion. Sixth, engage physicians. And finally, build improvement capacity. So let's talk further about the first 2 leverage points, which rest with boards and senior leaders. Leverage point 1 is to establish and oversee specific system-level aims for improvement. Specifically, governing boards must establish solid measures of system-level performance that can be tracked regularly to answer the questions, what are we trying to achieve, and how are we doing at it? Adopt specific aims for breakthrough improvement of those measures. To be realistic, these aims must be focused in 1 or 2 versus all dimensions of the care system. Establish effective oversight of those aims to answer the questions, are we improving, and are we on track to achieve our aim or aims? And while it may be tempting for a board to delegate adopting aims and overseeing measures to the CEO and senior leaders, this work must be led by the board so that the CEO and the organization as a whole see these aims and measures as priorities. And finally, commit personally to these aims and communicate them to all stakeholders. In many cases, hearing stories of how patients and their families have been impacted by quality events supports this process. Leverage point 2 is to develop an executable strategy to achieve the system-level aims and oversee their execution. Specifically, governing boards must work with the CEO and senior leaders to adopt a few focused breakthrough quality and safety aims as highlighted under Leverage Point 1. Since the remaining steps are management functions, they must be led by the CEO and senior leaders with support from the board only as needed. These steps include developing a plan with the scale and pace needed to achieve the identified aims, assigning capable leaders to key projects to address both big picture and day-to-day issues and make sure they have dedicated time to lead these projects, and reviewing and responding to data from the field at multiple levels to steer execution of the strategy to answer the questions, are we executing our strategy? And if we're executing our strategy, is it working? So now that we've talked about a framework for driving and sustaining transformation, let's focus on how to engage boards in PCHH transformation. You may be familiar with some of the information on these remaining slides. However, we provide these slides as resources that you can use and modify as needed to engage your board, staff, and other key stakeholders in PCHH transformation. The Primary Care Development Corporation produced Obtaining Patient-Centered Medical Home Recognition, a how-to manual. PCDC is a nonprofit organization dedicated to expanding and transforming primary care in underserved communities to improve health outcomes, lower health costs, and reduce disparities. The manual is a step-by-step guide to assist community health centers and other safety net providers in applying for and obtaining Ncqa Physician Practice Connections Patient-Centered Medical Home, or PCMH program. A link to the manual is provided on this slide. As highlighted in the manual, the first step is making the business case for PCHH. In making the business case, it's critical to start with the basics. First, describe PCHH and the importance of prioritizing patient-centered care. And second, explain the Ncqa recognition process. Let's start by talking about how to describe PCHH and emphasize the importance of prioritizing patient-centered care. If your board is not very familiar with PCHH, these slides may be particularly helpful in orienting them to the concept of PCHH. As defined by CPCA in its concept paper, Advancing the Patient-Centered Health Home in California's Community Health Centers, a PCHH is an approach that uses a whole-person orientation to provide comprehensive health care by facilitating an active partnership between patients, their families, and their primary care provider team to provide high-quality, timely care in a coordinated and consistent way. The basic tenet of PCHH is to reduce episodic sick care and move toward management of the patient and community to maintain their collective health. PCHH working principles include organized, effective, safe, evidence-based care, meaning that evidence-based care is provided routinely and clinical decision support tools and data are used to guide decision-making and ensure that care is delivered in a safe manner. Enhanced access, or access to care when patients need and want it. Empanelment, meaning that providers and care teams are familiar with and understand the group of patients for whom they're responsible. Patient, family, and community-centered, to encourage patients and their families to expand their role in decision-making and self-management. Cost-efficient and payment alignment, essentially payments based on performance and outcome measures that reward health maintenance versus episodic sick care. Continuity of care with a provider and care team to assure that patients are able to see their providers or care teams whenever possible, resulting in a continuous and team-based healing relationship. Coordinated, integrated care, including health promotion, preventive services, specialty care, hospital care, and care management, provided or coordinated by case managers, whether community health workers, nurses, or other members of the care team. Patient-centeredness, meaning that patients and families are viewed as integral parts of the care team. And data-driven quality improvement, essentially adoption of health information technology, including electronic health records and chronic disease registries, and accountability of care teams for patient outcome measures. At this time, I'd like to share a 4-minute video from the Patient-Centered Primary Care Collaborative entitled Introduction to the Patient-Centered Medical Home. This video is a multimedia presentation designed for consumers and patients and may be a particularly good resource if your board is not very familiar with PCHH.
Welcome to Emmy. I'm here to tell you about a better approach to healthcare, so let's get started. Okay, everyone's health needs are different, but whether you see your doctor once a year or a lot more often, it can be a hassle. First, it's often hard to get an appointment. You rush to get there, but you may end up waiting if they're running late. And your doctor's rushed too, so even though she'd like to spend more time with you, she only has a few minutes to find out what's wrong. The fact is, you may end up feeling like just a number, or just the next person in a long line. So your doctor only hears about your sore throat, or swollen knee, that pain in your back, or your daughter's cough, and there's no time for you and your doctor to really talk. It's even worse if you have a problem in the middle of the night, and you're not sure if it's serious. Do you wait and try to get an appointment? Or do you go to the ER, where the doctor doesn't know you and wants to run all kinds of tests? Will your insurance cover all those? It's a lot to deal with. And it's even more complicated if you need to see specialists, like a cardiologist, an allergist, or a dietitian. That's a lot of different healthcare providers giving you tests, prescriptions, and treatments. And no one provider knows what the others are doing. When you think about it, they're each just looking at a piece of you, so no one sees the whole picture. Shouldn't this be a lot easier and less confusing? Well, yeah, that's why there's a new approach to healthcare that puts all the pieces together. It's called the Patient-Centered Medical Home, and it's a way to give you better, more personal care. Now, even though it's called medical home, it's not a place. It's actually much bigger than that. It's a whole team of people who know you and work together to give you the best care. It's led by your personal healthcare provider who gets to know you well and works with people like nurses and pharmacists to make sure everyone's on the same page when it comes to your care. There are also people on the team to help you with things like medication costs or insurance questions. Basically, your team is made up of whoever you need, so it changes as your health needs change. For example, if you need a specialist, your team can help you find someone who's right for you, and your personal provider will keep up on everything and help make sure the whole team is in the loop about your treatment. In fact, many medical homes also use things like electronic health records to help coordinate your care. That way, you don't have to keep going over the same information with each healthcare provider. Look, your time is valuable, and your team knows you've got a lot going on. So with Medical Home, it's easier to get care when you need it. If you've got a problem at night or on the weekend, they want you to call. And you may be able to get the help or information you need without even going into the office. Or if you need to come in, the schedule during the week is actually a lot more flexible. So you can often get a same-day appointment, or even a longer appointment if you need it. But patient-centered care isn't just about getting help when you or someone in your family gets sick. It's about preventing problems so you stay healthy. They'll make sure you get things like a yearly checkup or any shots, and your care is tailored or custom-made based on your health and family history. So if you need any kind of test, they'll contact you to explain the results and schedule any follow-up care. Because once you have the whole picture, you and your provider can work together to make decisions about your health. It's a partnership, so speak up. After all, they want you to ask questions, and they want to hear about anything you'd like to change or improve. Do you need to get more sleep, lower your cholesterol, or lower your stress level? They'll help you set goals that make sense for you. Then it's up to you to make those changes and to let them know how it's going. And when it comes to things like asthma, diabetes, or high blood pressure, they know this can be overwhelming. So your team will make sure you get the tools you need. They'll also take time to explain everything, make sure you have the support and resources you need, and listen to your concerns. because caring for the emotional side is just as important as the physical side. After all, you're not just a name on a chart, you're a whole person. And with the patient-centered medical home, your team provides health care that fits your life. So you feel taken care of and, well, at home.
I hope you enjoyed the video. The video is available in English and Spanish, and a link to both versions is provided on this page. The Patient-Centered Primary Care Collaborative's mission is to advance an effective and efficient health system built on a strong foundation of primary care and the patient-centered medical home. It has more than 1,000 members, including the California Academy of Family Physicians, and has numerous resources on its website in addition to the video that we just viewed. A link to the Collaborative's website is provided on this page. Sutter Health, a network of doctors and hospitals in Northern California, also produced a video entitled Patient-Centered Medical Home, Stan Dawson. The Patient-Centered Primary Care Collaborative's video does a good job of explaining various aspects of PCMH, but you may find that the storytelling style of Sutter Health's video resonates better with some audiences.
Now that we've talked about how to describe PCHH and the importance of prioritizing patient-centered care, let's talk about how to explain the Ncqa recognition process. If your board is not very familiar with the Ncqa recognition process, these slides will be particularly helpful in orienting them to the process. In this document, the Ncqa Patient-Centered Medical Home Recognition Process, Ncqa outlines 7 steps. First, ensure that you have the information technology requirements to complete the recognition process. Second, identify key staff members who will be responsible for completing all necessary application information and the PCMH Interactive Survey System, or ISS. Third, determine if you have support from a sponsor, state, or organization. Fourth, participate in PCMH training. Fifth, complete the online application. Sixth, initiate the PCMH ISS survey tool and self-assessment. And finally, prepare the PCMH ISS survey for submission. Ncqa and Merck produced a video on patient-centered medical home that provides an overview of Ncqa's PCMH 2011 standards and processes, and other practical information that is intended to help organizations that are interested in PCMH recognition. A link to the video is provided on this slide. Ncqa has numerous PCMH resources on its website. A link to the resources is provided on this slide, and the red arrow shows where to navigate based on your organization's readiness for PCMH. Now that we've discussed the basics in making the business case for PCHH, let's talk about the specifics. First, highlight the short and long-term benefits of Ncqa recognition. Second, be clear about what resources are needed for the recognition process. And finally, be open to questions and provide additional resources as needed. Let's start by talking about how to frame the short and long-term benefits of Ncqa recognition. Benefits of Ncqa recognition include alignment with anticipated changes in reimbursement, recognition as a leader, improvements in recruitment and retention, improvements in quality, and cost efficiencies. Let's take a closer look at each of these benefits.
While no systematic changes in reimbursement have been instituted, Ncqa-recognized organizations will be in line with anticipated changes in reimbursement, including the trend to pay for quality and value. Payers, including the Centers for Medicare and Medicaid Services, or CMS, Health Resources and Services Administration, or HRSA's Bureau of Primary Health Care, public and private payers, and foundations are increasingly driving PCMH recognition through demonstration and other types of projects because they desire both better health outcomes and cost savings. Over the past few years, numerous PCMH demonstration projects based on the Ncqa PPC PCMH program have emerged. These projects include the CMS and HRSA FQHC Advanced Primary Care Practice Demonstration Project with 500 sites across the country, including at least 70 in California. Organizations in these demonstration projects typically receive additional payments, often on a per member per month basis, to cover additional care coordination and management costs. In addition, many demonstration projects also give providers bonuses for performance, again often on a per member per month basis. Another benefit for Ncqa recognized organizations is acknowledgement as a leader in the field. The Ncqa PCMH 2011 recognition program is the first and most widely used program from a national quality oversight organization. It is an expansion of Ncqa's PPC recognition program that was initiated in 2003 with support from the Robert Wood Johnson Foundation, the Commonwealth Fund, and Bridges to Excellence, and evolved into the PPC PCMH 2008 program. The PPC PCMH 2008 program was developed with input from the American College of Physicians, American Academy of Family Physicians, American Academy of Pediatrics, and American Osteopathic Association, all authors of the 2007 Joint Principles of the Patient-Centered Medical Home. Ncqa has a brochure that provides more detail and may be helpful for board members who are not familiar with the 2011 program. A link to the brochure is provided on this slide. Improvements in recruitment and retention of providers and staff are another benefit of Ncqa recognition. PCMH represents the future model of primary care, and it is being incorporated into the basic training of primary care residency programs. Therefore, Ncqa recognized organizations will be attractive to residents and new physicians, as well as other providers who are interested in being involved with community clinics and health centers that are using this model. As suggested earlier, another benefit of Ncqa recognition is improvements in quality. Organizing care around the patient, making patient-centeredness a priority, and coordinating care and managing information contribute to quality improvements. The Patient-Centered Primary Care Collaborative released a brief entitled Outcomes of Implementing Patient-Centered Medical Home Interventions, a review of the evidence from prospective evaluation studies in the United States. A link to the brief is provided on this slide. In its brief, the collaborative concluded, investing in primary care patient-centered medical homes results in improved quality of care and patient experiences and reductions in expensive hospital and emergency department utilization. The collaborative went on to say, there is now even stronger evidence that investments in primary care can bend the cost curve, with several major evaluations showing that patient-centered medical home initiatives have produced a net savings in total healthcare expenditures for the patients served by these initiatives. Finally, cost efficiencies are also a benefit. Ncqa recognized organizations commit to creating efficiencies in the care team by defining roles and distributing tasks among care team members to reflect the skills, abilities, and credentials of team members. In addition, the literature has shown that PCMH reduces the cost of care on some measures, such as use of inpatient care and emergency room visits, particularly for patients with chronic conditions. Now that we've talked about how to frame the short and long-term benefits of Ncqa recognition, let's talk about how to be clear with the board about what resources are needed. Resources needed include a strong project leader, key staff members including representation from administrative, clinical, and information technology departments, protected time for the team to meet and complete the survey process, particularly since the recognition process can take at least 6 to 8 months to complete, and technology, including enhancements to existing systems and/or purchase of new systems. Finally, it's important to be open to the board's questions and provide additional resources as needed throughout the process. Links to some of these resources are included in the slides at the end of this module. We've talked about making the business case, the first step in engaging boards in PCHH transformation. Now let's talk more specifically about the next step, the board's specific role in PCHH transformation. The Safety Net Medical Home Initiative was started by the Commonwealth Fund, Qualis Health, and the McCall Center for Healthcare Innovation at the Group Health Research Institute in 2008. The initiative is a 5-year demonstration project to help safety net sites become high-performing PCMHs and achieve benchmark levels of quality, efficiency, and patient experience. One of the Safety Net Medical Home Initiative's products is a series of implementation guides, including one on engaged leadership. In its implementation guide supplement entitled Engaged Leadership, How Health Center Board Members Can Support Medical Home Transformation, the initiative outlines 4 roles. First, build PCMH into your health center's mission, values, and vision. Second, recruit and support leadership. Third, build a culture of continuous quality improvement and hold health center staff accountable for that improvement. And fourth, delegate resources. There are a variety of other resources on the Safety Net Medical Home Initiative's website, and a link to the initiative's implementation guides, including Engaged Leadership, is provided on this page. Let's talk about the board's role in PCHH transformation, modified within the context of the Safety Net Medical Home Initiative's framing. Let's start by talking about supporting leadership, and specifically how you can support the board with managing change related to transforming to a PCHH, and similarly, how you might ask the board in return for support in managing change. As we highlighted earlier, PCHH is about transformation or change at many levels. As outlined by NAC in a document from its 2011 Policy and Issues Forum, community clinics and health centers face a number of changes when transforming to a PCHH. These changes include embedding PCHH in the organization's vision, developing the business plan that includes PCHH, including budget, staffing, and expected results, identifying a team to guide the transformation process, establishing a communication strategy that informs board, providers, and staff, scheduling provider time beyond direct patient care, building PCHH into staff hiring and training, capturing data related to PCHH and including clinical leaders involved in PCHH in the design and interface of information technology and electronic medical records, and identifying the level of involvement of providers, staff, patients, and families in planning, implementing, assessing, and improving changes related to PCHH. The CEO's role is to help the board understand the scope of these changes and understand the impact of change on the organization so it can support the CEO and senior leaders in managing change and transition.
As we know, change is inevitable and complicated. With that in mind, let's talk briefly about managing change. Let's start by reviewing the difference between change and transition. Dr. William Bridges is a California-based consultant who speaks and writes extensively about change. He defines change as external and situational. Under this definition, change might include PCHH transformation. In contrast, he defines transition as internal or psychological. Transition is the process that we go through to come to terms with change. Now that we've had an opportunity to think about managing change, let's focus on managing transition. This slide shows the three phases of transition that Dr. Bridges defined. The three phases are endings, neutral zones, and beginnings. On the left side of the diagram, you see the transition begins with endings. In this phase, we experience loss and begin a process of separating ourselves from what used to be, from roles, relationships, and processes. As we move out of endings, we move into the neutral zone in the middle of the diagram. In this phase of transition, we often feel uncertain, perhaps even fearful of what the future holds. We may have mixed feelings about the change we've experienced and be reluctant to move forward. It's important to note that some individuals never let go and stay in the neutral zone, and our role as leaders is to confront and manage that resistance to change by providing coaching and support. As we move out of the neutral zone, we move into beginnings on the right side of the diagram. In this phase of transition, we begin to embrace change. We begin to be clear about the future and often begin to have positive feelings and a renewed sense of purpose. To successfully manage change, we need to help individuals and teams work through the three phases of transition. You may be familiar with Dr. Elizabeth Kubler-Ross's book on Death and Dying and the 5 stages of grief. Dr. Kubler-Ross talks about 5 stages of grief: denial, anger, bargaining, depression, acceptance, in terms of personal tragedy or loss. However, because transition is psychological, an additional way to help you think about how to manage transition in your organization is to think about how these stages of grief align with Dr. Bridges' phases of transition. In this slide, you see that in endings, we often experience the first 2 stages of grief, denial and anger. As we move into the neutral zone, we experience the next 2 stages of grief, bargaining and depression. And finally, we move into beginnings. We reach a stage of acceptance. As with any model, the stages of grief may not be so clear. Individuals may only experience a few of these stages, or, like the boat in the diagram, may drift forward and back, depending on the waves. Now that we've had an opportunity to think about the 3 phases of transition, let's look at 3 key questions that the CEO and senior leaders should be able to answer before even introducing a change to the board, staff, and other key stakeholders. 1. What is changing? 2. What will actually be different because of the change? And 3. What is lost?
My colleague April Pace and I completed a change management module for CPCA. For more information about managing change, visit the CPCA website at the address provided on this slide to access the change management module. Now that we've talked about ways to address the board's first role, to support the management of change and transition, let's talk about ways to address the board's second role, to ensure that PCHH is integrated into the mission, vision, and values of the organization. To ensure the integration of PCHH, one of the key questions that you and the board should reflect on is, do your mission, vision, and values include specific references to patient-centered care and/or patients and their families? In the next 3 slides, we present examples of California Health Center's mission statements. Here's the first.
Santa Rosa Community Health Centers is dedicated to providing excellent patient-centered primary health care and health education to underserved people in our community, regardless of their ability to pay. We are dedicated to caring for the whole person with dignity and respect. SRCHC is committed to the education of healthcare professionals and to creating a continuous learning environment for all staff.
Here's the second.
Borrego Health provides high-quality, efficient, customer-focused health care to the communities we serve, accomplished by providing access to patient-centered comprehensive care to all residents, regardless of their ability to pay.
And finally, here's a third example that doesn't include the word patient-centered, but still includes specific references to patients and their families.
The Children's Clinic mission is to provide quality, integrated, innovative health care that will contribute to a healthy community focusing on those in need and working with patients and the community as partners in their overall well-being.
Another key question that you and the board should reflect on is, do you address PCHH in strategic planning efforts? Specifically, do you have PCHH goals, and do you have systems for accountability for reaching those PCHH goals? Another key question to reflect on is, do job descriptions include references to patient-centered care and/or patients and their families? Here's a job announcement for an on-call nurse practitioner at Mission Neighborhood Health Center. In the orange oval, you see the statement,
They will support team-based healthcare and work with MA and other support staff to help the clinic meet the goals of patient-centered medical home status. Specifically, excellent patient access, electronic health records with meaningful integration of data, panels of patients managed by teams, effective coordination of care, population-based patient data, and engaging patients in self-care goals.
And here's a job announcement for a registered nurse at West County Health Center's Sebastopol Community Health Centers. In the orange oval, you see the statement,
We have strategically positioned West County Health Centers on the leading edge of primary care transformation towards a patient-centered health home, and advanced nurse care management is at the heart of this transformation. We are convinced that it is the future of healthcare because it is the right thing for our patients.
And finally, a key question to reflect on is, do you include information about your commitment to patient-centered care in education and marketing materials? Specifically, do you educate patients and their families about PCHH, and do you invite patients and families to share their experiences and ideas? At this time, I'd like to show a 7-minute video from Santa Rosa Community Health Centers. While you certainly don't need to create a video to share your commitment to patient-centered care, the video includes some great messages that you may want to consider including in other types of education and marketing materials, such as brochures and patient orientation packets.
A little more than a year ago, I was involved in a head-on collision with a drunk driver. I was uninsured. I was unemployed at the time, and I didn't know where I was going to turn to get any type of help. I was too overwhelmed. I was beyond hope. And I really wished a lot of times I did not survive this accident. And they had sensed that. They had sensed that I was really hurting in more ways than just pain. Southwest Community seemed to take a lot of that fright away from me. They let me know that I am a worthwhile person that deserves any medical assistance they can provide or that I need.
Home. Home. There's no place more comforting, more welcoming. Home is about warmth, security, family. Home is our place of refuge, our sanctuary. Now, there's a healthcare organization built on the experience of home. Since 1996, Santa Rosa Community Health Centers has provided excellent primary care, prevention, and health education for people in Santa Rosa regardless of their ability to pay. To continue that mission today, we're committed to a patient care model called the Patient-Centered Medical Home. It's a model of care that puts the needs of the patient first, making sure they feel welcome, they are heard, have a personal connection with us, a relationship of trust and respect.
We have a team-based approach to our medical home, and what that means for us is that each patient has one primary contact, which is their doctor or their nurse practitioner, and all around that relationship of the patient and the doctor or nurse practitioner, there's a whole team of people there ready to support and guide decisions that would have to be made. We start with the receptionist out front, the medical assistant in the back office, mental health providers, nutritionists, and health educators. And if we imagine all of these people working around the patient to assist with healthcare decisions, we end up with a much more powerful result.
We take care of patients from birth to death and at every stage in between. All of those patients deserve the very best health care in the world. And with a patient-centered medical home model, we can deliver the best health care in the world that's comprehensive, that's coordinated, and that's based on really listening to what patients need and want and delivering a plan with them that works for them.
We consider the patient's needs in other ways too. Access to quality medical care is a cornerstone of the medical home approach, so we offer expanded hours, convenient schedules, and on-site laboratories. Our 9 unique locations allow patients in Santa Rosa to access care where they live, work, or go to school, whether that's Roseland, downtown, or the northeast part of the city. Our electronic medical record system brings ease to patient visits and guides our medical priorities by helping us see health trends among our patients. As we continue to grow, Santa Rosa Community Health Centers generates hundreds of quality jobs and puts over $20 million per year into the local economy.
I think those of us in business know ultimately at the end of the day, our success is going to determine how healthy the community is. Financially healthy, physically healthy, mentally healthy. In these difficult days, these challenging times, when all of us are just one financial setback away from not having access to medical care, Santa Rosa Community Health Centers is a tremendous resource for all of us. Over the next year alone, Santa Rosa Community Health Centers will respond to tens of thousands of patient visits and deliver quality care, and at a cost that is 1/4 of that of an emergency room service. I believe that when you're fortunate enough to have both quality and efficiency in one medical package, that is a powerful contribution to all of us.
And the real bottom line? Through our excellent medical care and personal approach, kids stay in school, adults stay productive workers, families stay healthy and together. We are thrilled to partner with the Santa Rosa Family Medicine Residency to nurture patient-centered healthcare practices in our future family practice doctors. Our staff of over 300 passionate healthcare professionals serves 40,000 patients with 150,000 patient visits every year. The services we offer are comprehensive, state-of-the-art, lifelong, culturally relevant, compassionate. Home, comfort and security, a refuge of health, hope and healing, a sanctuary where all are welcome, clearly heard, valued, and respected. All made possible through the patient-centered medical home.
Southwest Community can do everything in the world for a person, and it's not going to help unless they're willing to help themselves. So that's what they gave me a chance to do. They gave me a chance to help myself. When I finally came to the realization that everything was going to be all right, when I was walking in the clinic on my own. And I knew I had a chance. And I feel they had given me that chance. It didn't come accidentally. So I'm grateful for that.
This is an issue I feel really passionate about. Healthcare is a social justice issue. All people deserve access to high-quality care so they can live a healthy and productive life, contribute to the community, raise their children, get an education. Santa Rosa Community Health Centers is a community asset, and we need the community support.
To learn more about supporting the work of Santa Rosa Community Health Centers, please visit our website or call 707-303-3617.
Now that we've talked about ways to ensure that PCHH is integrated into the mission, vision, and values of the organization, let's talk about ways to address the board's third role, to ensure allocation of necessary resources. One of the key questions for you and the board to reflect on is, Do you have the necessary resources for PCHH staffing and infrastructure needs? As we noted earlier, staff may need protected time for new responsibilities, and there may be a need for technology enhancements and upgrades. Another key question is, what are opportunities for PCHH payment? Finally, let's talk about ways to address the board's final role to ensure integration of PCHH into quality assurance and quality improvement efforts and monitor performance. One key question for you and your board to reflect on is, are you collecting PCMH-related data, including data on clinical quality, patient experience, provider and staff satisfaction, practice transformation, and efficiency and cost or revenue? Another key question is, how do you ensure the provision of high-quality, patient-centered care? Collecting data is important, but using those data to drive improvement is at the core of PCHH transformation. Here are a few links to resources. This concludes our online training session on engaging clinic boards in patient-centered health home transformation. Again, this module is part of a series of online courses provided by the California Primary Care Association as a demonstration of its mission of strengthening its member clinics and networks through advocacy, education, and services in order to improve the health status of their communities. For information on other online training opportunities, please visit the websites for California Primary Care Association and Ncqa. Thank you for your participation.